Welcome to our presentation about how to present work productivity loss due to health problem in clinical trials. My name is Jasmine Kleher. I am a PhD candidate at the University of British Columbia. I'm supervised by Dr. Wei Zhang, which was the principal investigator on this research.
My name is Lin Chen. On this project, I served as the patient partner. I am affiliated with Patient Voices Network. Before our presentation, we would like to acknowledge that this work has been conducted on the traditional and ceded ancestral territories of the Coast Salish peoples, including Musqueam, Squamish, and Tsleil-Waututh nations. We'd also like to acknowledge the support from BC Support Unit for its Methods Cluster Award and the contributions from other team members listed here. In our presentation, we will first talk about why it is important to measure work productivity loss. Then we'll speak to our findings on how to present work productivity loss results.
Work productivity loss includes three main components: absenteeism, that is when people are absent from work due to health problems; presenteeism, which refers to reduced work productivity while working; and employment status changes, which captures changes in work time. For example, changing your schedule from full-time to part-time, or even stopping to work completely. Work productivity loss has been considered as one important patient-centered outcome. For example, research has shown that work productivity loss is an important outcome for people with arthritis. It has been recommended as an outcome measure in rheumatology research, and work productivity loss is also included as a cost component in economic evaluation performed with a societal perspective.
As a patient partner, I did not know much about work productivity loss initially. Through this project, I came to realize how this is a common issue experienced by many family caregivers. I really appreciated the opportunity to learn more about ways to measure and communicate the results.
To give you a bit more context to work productivity loss from absenteeism, in Canada, based on the labor force surveys, the number of absent days per full-time worker increased in recent years. A report by the Conference Board of Canada estimated the cost of absenteeism to the Canadian economy to be $16.6 billion in 2011. Turning to the impact of presenteeism, Goetz et al. Is one of the few studies that estimated all direct costs, as well as absenteeism and presenteeism for different chronic conditions among employees in the United States. It shows that absenteeism accounted for 3 to 29%, while presenteeism accounted for 0 to 55% of the total cost. Lastly, for employment status changes, among an early rheumatoid arthritis cohort, you can see that about 20% of patients stopped working due to the disease within 10 years after they had symptoms.
Next, we're going to turn to address how to present work productivity loss results from clinical trials. Before we continue, I'd like to explain that by work productivity loss results, we mean work productivity loss due to health problems for patients and due to caregiving responsibilities undertaken by caregivers. I would like to preface by saying that we are still in the analysis stage for this project, so we'll be presenting preliminary findings. For this project, we use a mixed methods approach with a sequential design, having our qualitative strand inform our quantitative strand. In the qualitative portion, we did 2 rounds of interviews with patients and caregivers who were our 2 target populations. Our first round focused on gathering feedback on the work productivity loss results themselves, while our second round focused on gathering feedback about the results and survey design. The recruitment was done through ReachBC between September 2020 and April 2021. Following a few interviews iteratively, we reviewed as a team and edited applied suggestions made in the interviews to the survey results. Speaking about it from the patient partner perspective, I want to share that here are some things that I was asked during the development of the survey. These included questions around whether the section of the survey was easy or hard to understand, the clarity of what was expected in each of the survey sections, whether I liked or disliked certain sections of the survey, whether I would change anything about the design of the survey section, and whether there were any sections that were unanswered or instructions that were missing from the section of the survey. During this process, I also had the opportunity to contribute to the wording and presentation of the results, drawing from my personal experience as a patient partner and family caregiver. Some of the main changes that we applied following the qualitative interviews include, first, providing lay terms of what each work productivity outcome meant. This was especially stressed for presenteeism and employment status changes. Second, adding visual support for each result. Third, making it clear when we're reporting a result for the group affected by the outcome versus that of the whole group. Fourth, when reporting results in terms of cost, we had provided examples of calculations.
Now I'm going to turn to our quantitative strand. We surveyed 118 patients and 120 caregivers between June and August 2021. We set our survey quota using the Canadian working population as targets, from whom work productivity is most relevant. The survey structure from one section to the other was repetitive. First, we asked about the understandability of each result within that section. Second, we ask about the importance to report each result. Then we ask about which results are most important to report in the form of top 3 result and top 1 result. And finally, we ask about the importance of reporting each work productivity loss outcome. In brief, our resulting sample were similar for caregivers and patients, with slightly more men than women in each group. Most respondent aged 25 to 44. Their education level were also similar, with bachelor's degree or above being the most common. We did capture more socio-demographic information, but we're not reporting those for the sake of time. Turning to the understandability level of the result for each outcome, the percentage of respondents that identified each result as very easy or easy is similar for patient and caregivers and ranges roughly from 61 to 93%. The result within each outcome that got the highest percentage of very easy or easy to understand were a result using days and cost. Using the absenteeism outcome as an example, the format of these results were overall, the average number of missed work days for patient in group A was 18 days, and for patient in group B, it was 45 days. And the cost of missed work days was $2,880 for those in group A, and for those in group B, it was $7,200. The result within each outcome that got the lowest percentage of very easy or easy to understand was our result showcasing the subgroup result. Again, using absenteeism as an example, the format of that result was, among those who had missed work days, The average number of missed work days for those in Group A was 60 days, and for those in Group B, it was 90 days. Moving to the importance to report each result, the percentage of respondents that identify each result as important or somewhat important to report is similar for both patient and caregivers and ranges roughly from 65 to 92%. The result within each outcome that respondent identified in the highest percentage as important to somewhat important to report were a result using days and cost. The result that had the lowest percentage were the subgroup result and the percentage of people result, which is shown above. The result selected in the highest percentage by our respondents is shown here and alternates between days and cost. These results were chosen by 65 to 81% of all respondents. When asked about the result most important to report, for most outcomes, cost obtained the highest percentage. When cost was first, days came in second place for all outcomes. Lastly, all work productivity loss outcomes were identified as important to somewhat important to report by 78 to 95% of patient and caregivers. To go over some limitation of our study, we tested the result only in English. However, we did have some non-English native speakers in our interviews. Because this is a very unique study, we focused on the foundation, and the result we presented did not relate any uncertainty. So for example, we did not include any standard deviation. In our qualitative round, all of our participants but one were located in BC. In our quantitative round, we only tested in Canada. We also had no respondent in the territories, but Quebec as a province was included. We had relatively small sample size, and we also did not ask our participant if they had any pre-knowledge of work productivity loss result or outcomes, or if they had themselves experienced these outcomes.
In conclusion, what we learned in our qualitative strand is as follows. Both populations stress the importance of using lay terms to relay results in a quick and easy manner. As well, both populations stress the importance of using visual support to showcase each result. As well, both populations stress the need to provide clear explanations about what each outcome means. For our quantitative strand, we learned that patients and caregivers identified the same work productivity loss outcomes to be important. Furthermore, patients and caregivers identified the same work productivity loss results as important to report for all outcomes, which were days, cost. In terms of our future analysis, this would include looking into the correlation between understandability and the importance attributed to each result, and looking into how demographic factors may impact how respondents rate the understandability and importance of results.
Thank you for listening to our presentation.